So another installment in the ongoing saga of quality improvement at HSN Emergency Department. These videos take a lot to put together, but I think people like them. I think they find them useful. And there wasn't particularly good attendance at our last round, so hopefully this will get the word to more people. I have 13 points to talk about, but hopefully it'll only take about 10 minutes. So first off, the perennial inpatient problem. Remember here that the goal is to share the burden of overcrowding, which exists. It's a problem. It probably exists in every hospital, but our argument is that we need a fair policy because, as you can see from this picture that Steve took of our emerge on December the 8th, we are disadvantaged by the unfairness of the system as it stands. So as we learned, the policy to share this burden is with the fire marshals currently. And so I've been phoning the fire marshals with frequency over the last couple of months, trying to get some answers as to where it stands. Unfortunately, a lot of the members seem to be almost impossible to talk with. I'll keep trying, and hopefully we can get some answers soon. In the meantime, though, perhaps we want to consider a letter to the fire marshal as a different venue of communication. Evaluations. So those are going to be rolling out this week, courtesy the Chief of Staff. Thanks, Chris. I took a random selection from all our docs. I excluded Doctors Marchadier and Moore because they're already doing 360s, and the winners are Gary Boda, Marc Dubé, Pavan Coca, Rob Lepage, and Sam Stone. Congratulations. So hopefully you'll see those next week. In a similar sort of vein, report cards. Basically, this is taking, I crunched a bunch of numbers, but that was pretty time consuming. So the idea is to automate the process so that we can have these every quarter or every term or annually. But, I think the more often the better. The metrics we were looking at, 3-day admitted bounce backs, time to first PIA, test ordering, and the individual's effect on the average PIA and ED length of stay. Shoepocalypse 2016. So this is probably the greatest CQI project I've ever done. Much more innovative and idealistic than even early assessment MD. Those, someone put a whole bunch of shoes into 2 boxes, and those boxes have been sitting there for almost probably at least a year. I took those shoes today and I put them all in the doctor's office. That's the penultimate stop on their way to the Salvation Army. I encourage you to look through those boxes, and there are even some nice shoes like these ones, although they're a bit dusty. And if you find them and they're yours, then keep them, or even if they aren't yours but you like them, keep them, because otherwise I'll be dusting them off and bring them to the Salvation Army in a couple weeks. Examination tables. So there's lots of evidence to support this. So the subjective evidence falls into 3 categories. The MDs in the department. So there's lots of times where we can vouch for there's a lack of examination space. The RNs are on board with that. I've spoken with a few of them, and they all recognize that when there are no rooms in OBS, there's a problem. The department becomes constipated. Consultant opinion as well. So Marco Duich, in the few times that we've been talking to him, he's cited getting examination tables in as one of the reasons that Southlake and St. Joe's in Toronto are so fast. And then above and beyond subjective data, there's also objective data from our own experience. So we had the OBS pilot, and you can compare the month from June 23rd to July 23rd, 2014 versus 2015. Our volumes and our inpatients were roughly about the same, but in comparing those 2 time periods, our PIA times went down by 52 minutes. And that wasn't an effect of 1 or even a few days. That was, as you can see from this graph, almost evenly distributed across the month. So when we have space, this graph proves we are better able to do our jobs. So I'll be presenting all this evidence to Lisa when I meet with her, hopefully next week. There was a discussion about this at our last rounds, and we agreed that a good idea would probably be to start with 1 or 2 examination tables and see how things go from there. So I'll be talking with Lisa next week about that. Clinical pathways, I've discussed 1-hour troponin algorithm, and you've probably seen it floating around the literature. I've spoken with Dr. Anuska from the lab, who's since moved on to Barry, and Dr. Wong. They've been instrumental in pointing me in the right direction, but I think the real work is going to happen at a February journal club organized by Sam, in which cardiology is going to be present. We're going to be talking about some of these algorithms and some of the latest guidelines. Other pathways we've yet to discuss. We've been trying to organize a meeting with Drs. Cameron and Dr. Paranam since well before Christmas. That's still pending, but hopefully we'll get in touch with them and be able to streamline our care between the ED and internal medicine. Chest X-ray directive. This is not for this particular patient, but for patients with CHF or COPD who present with shortness of breath or a productive cough, we'd like to get a chest X-ray up front along with their blood work. As it stands currently, 92 to 94% of these patients are getting a chest X-ray anyway, so it's pretty much universal. This is supported by guidelines, the Canadian Thoracic Society and the Canadian Cardiology Society. It's mandated in the provincial QBPs that are coming out, and we've talked about it at rounds and thought that it was a good idea. So Rob will be discussing this with Verge and Jamie this week. The early assessment MD has been pretty successful, I'd say. I was pleasantly surprised by it. The PIA, we found that we're technically able to get it to 0. The left without being seen obviously is also 0 for those patients who go through it. The nurses with whom I've spoken seem to like it, and the patients really like it. So I think it's a pretty universal win. I was also pleasantly surprised that the EDLOS actually seems to go down with it as well, and you can compare these intraday comparisons, these intraday numbers. I was worried that the EDLS might go up. It might be a bit sacrificed by gains in PIA, but that doesn't look like it's the case, especially here at the start of December when we were doing it quite frequently. You can see that this really allowed us to meet our targets, whereas the other patients we were missing our targets. So I think this is there's potential here. The participation has been falling off, but I think if we just remind ourselves from time to time that it's an available option and we do it when the situation is appropriate, I think it has real benefits to patients, to ourselves, and to the department as a whole. Manpower, I know I've shown this slide a lot, and I keep coming back to it. It's one of my favorites, and I think it's probably the most important thing I've done in my time as medical lead of CQI. This graph really shows the problem with our department, and in particular this area shows why at 7 o'clock at night we have patients waiting 3 or 4 hours. It's because of this. It's because during the middle of the day we're unable to keep up with the incoming tide of patients. This is where a flex shift would really fit nicely, from 9 to 2 or 9 to 3 in there, so we can really get on top of this wave. So Rob has pushed hard to get people to fill flex shifts, and I'd really encourage people to do so because this would help. The other thing that I've tried to demonstrate with this graph here is that there's lots of variability. So we can't build one universal schedule. We have to be adaptive. And this graph shows that not only is there intra-hour variability, there's also, intra-day variability, there's also inter-day variability. So these are 2 Fridays, not particularly special Fridays over the last data set that I analyzed. One had 169 patients, the other had 229. So very different days, and there's no predicting that. So we need a flexible schedule. And fortunately, I was much surprised, and heartened by these two numbers from the survey that Rob sent out. Most people, by a vast majority, are willing and able to commit to an extra shift per month to do flex to fill that gap. And most people as well, by a slightly smaller but still large majority, are willing to have a voluntary call-in shift. So I know a few of us have been doing this. If the department looks like heck and I'm working the next shift, give me a call. I'll see if I can come in early. And, you know, I hope everyone would do the same as well. In order to support you in doing that, if, you know, you're eating your Cheerios at 9 in the morning and you're working the 11 a.m. shift, you can log in from home, see how the department is doing. And if you notice that the numbers are already starting to creep up, or if you notice that there are a lot of people out in triage, then maybe consider coming in at 10. And now this little icon here, ED Whiteboard, allows you to do that. The other thing with the whiteboard that we talked about was the unfairness, and this was sent to me by Amy, who is charge nurse this day, and she notes this unfairness. She knew I was looking into this, but this is completely unsolicited. She highlighted and circled these numbers here. It's kind of unfair, probably, that a 42-year-old with a cough is going to be seen well before a 67-year-old with abdominal pain, and we can all, you know, think of more egregious examples than that. This is currently in the hands of management. Rob sent out an email, and there's some great discussion points from Christine and from Steve. This is currently in the hands of management, and I think perhaps we'll be going to a combined CTAS and length of stay amalgam to sort this list so that people get seen in a more timely fashion, even if they are CTAS 3 or 4. The last thing I have is direct consultations. So just a reminder that we did decide, we talked about a lot of the benefits that can happen if we just see these direct consultations ourselves and see them early. In December, I just analyzed some data, and we had 21 direct consultations, but 4 had pretty prolonged times, you know, from 140, so greater than 2 hours, to 219 minutes, you know, verging on 4 hours before they were seen by anyone. The average was 60 minutes, which in comparison is not much different from what we were doing in the previous data set that I looked at, which was 64 minutes. So just a reminder to get out there, see those. If you see a direct consultation, just pick it up, say hello to the person, and get on the phone to the consultant. The other thing that'll do is, you know, if the consultant's not aware, or the consultant thinks it's okay to keep the patient sitting in emerge, it might push them a little bit to get the patient seen and assessed and sent home or upstairs or whatnot, so that we can clear some space in the emerge. Anyway, that's it for this update, this installment of CQI Update. Thanks for listening.